Hello, Joe 200. It's the two of us this week talking about week 5, which is cancer and grief, death, and dying. And before we get started on the material, I wanted to remind you that tomorrow your week 4 assignments are due. So that reading, quiz, and discussion are due tomorrow, Monday, February 6th by 11:59 p.m. Blackboard closes at exactly 11:59, not 11:59 in 2 seconds. So get in there before the deadline, get your stuff in.
Yeah, if I was you, I'd wait till like 11:59, and then that's when I would do it.
Sarcasm.
Yes, okay.
Okay, and then the following Monday, February 13th, you have your first written assignment, the CT1. So that's about a 2-page paper, not including your graphs and charts. John will send out a video explaining how to do it. I will send out an email with some tips. Here's the things where people usually lose points. And if you have any questions, let us know. You can reach out. We can Zoom. You can email me. If I don't answer your email same day, email me again, because I do get a lot of emails and I don't want to miss anybody.
And this is the video I did last semester. I do one every semester. So if you don't want to wait for the one I'm going to do this semester, you can look at this one. It's the same drill. The assignment really hasn't changed. But we do check for plagiarism, so don't copy somebody's from last semester.
Don't cheat.
No,
we'll figure it out.
no. Okay.
So let's go into the weekly assignments. Okay. We're going to talk about the reading was about cancer. And I always ask John, can I help with this lecture? Because I'm a cancer patient and I'm very passionate about cancer treatment, cancer prevention, and just, what's going on in the world of cancer. So I've kind of become a student of cancer as a cancer patient.
And so we're going to put the video right here, my friends.
Yes.
Okay.
So one thing I want to remind everyone is getting a cancer diagnosis is never fun. There's a process of coming to grips with the fact that you've gotten this diagnosis. It's something that most of us will have to deal with in our lifetimes, either with our own cancer diagnosis or with a loved one or a friend or family member or neighbor. The general statistics right now say that 1 in 2 men and 1 in 3 women will be diagnosed with cancer in their lifetime. That's the bad news. The good news is that for those of you who are younger, the risk is fairly low when you're younger. It goes up quite a bit over 50, and then over 70, it really skyrockets. So you start to get into that 1 to 3.
The nature of this class. What is the biggest risk factor for cancer? Age.
So we see a lot of a much higher cancer rate for most cancers when you get older and your immune system starts to slow down a little bit. And so your body is constantly surveilling what's going on in your body and like, oh, that cell doesn't look right, I'm going to kill that cell.
I mean, you guys all have cancer cells. You do, all right?
But
now.
You are young and strong and you can
your immune
off.
system is like, oh, that doesn't look normal, and it prunes it. The other thing that happens with aging is you accumulate mutations over time, and slowly but surely the mutations are going to make the cells divide a little more quickly than they should, and then all of a sudden it starts, basically piggybacking on each other, and then all of a sudden, boom, it takes off. So.
Yeah. Now we are in a very exciting time for cancer research, and we're seeing some very rapid progress in cancer treatments. And so we're seeing that reflected in the data that we look at. Now, all the data that we study, and every year there's a new report that comes out. We use the GERO report, which is the national report from the National Cancer Institute. Comes out every year. This most recent version came out in October 2022. And it's a look back. So it's looking back usually, a couple years in the past. So it doesn't reflect the most recent treatments. So it's always going to be a little bit worse than what would happen if you got diagnosed with cancer today.
Because it takes time to gather data.
Do not panic if you look at, if you or a friend or a loved one gets diagnosed with cancer and you go on the internet and you see horrible news. It's better than it looks. Right. So every year the GERO report comes out, and I rely pretty heavily on the GERO report and also a really great report that the American Cancer Society puts out that's cancer statistics every year.
So all the data that we're presenting is from 2015 to 2019.
Yeah, for the most part, yeah. So when we look at this GERO report, what they talk about is that we have declining death rates in cancers that have been problematic in the past. Lung cancer and melanoma are 2 cancers that were difficult to treat, but we've got new checkpoint inhibitors that activate your immune system and tell your immune system go after these cancer cells and really, really kick ass on these cancer cells. So we're seeing a lot of improvement fairly quickly in terms of lung cancer and melanoma.
And it's really innovative, so it doesn't have the downsides of chemo. But oftentimes it's still going to be done in combination with chemotherapy, but you just don't have to rely 100% on chemo. So,
Yeah, and that's another good point. A lot of people are afraid of cancer treatment, but what we're seeing with the newer therapies, for example, the therapies that I had a combination of an immunotherapy that was an antibody against my cancer cells and a targeted therapy, and neither one was chemotherapy. So the therapy that I had was very easy to tolerate. There's always some side effects.
No free lunch. No free lunch. There was some
But
problems.
it was not bad. It was a lot better than I even expected when I started treatment.
Right.
Okay, so let's go down a little bit. Okay, and there's good news for what we call the adolescent and young adult population, AYA. They are also seeing a decrease in cancer death rates and even more of a decrease among children. And that's partly caused by the fact that we see a very high rate of clinical trial participation among children. And so the progress of research in that area goes a little faster. And so
there's nothing more kind of scary than having a child get cancer.
Yes, exactly, exactly.
When you're older, you're still shocked, but like, God, I've lived a good life, but to have a life stolen like that, and that was, the Emperor of All Maladies. The focus of that amazing book and series is on childhood leukemias because they used to be such a death sentence for little kids, and not anymore.
Absolutely. So the survival rates have gone up quite a bit for children, adolescents, and young adults who are diagnosed with cancer. Okay, keep going. So what do we, before we get too far, I want to talk about cancer incidence rates and cancer mortality rates. Typically what we see expressed is the cancer incidence rate, which is new cases per some segment of the population. Typically it's 100,000 of people at risk. So if you're looking at breast cancer, you're going to look at 100,000 people who have breasts and figure out how many of those people got breast cancer.
And then for epidemiology, the way because they talk about incidence and prevalence, the way I remember incidence is incidence is for increase, increase. So it's the increase that year.
The new cases. And then mortality is the same thing. It's the number of people who died from this cancer this year from the population that was at risk.
And that's what's being shown in this figure right here.
Okay, and then this is talking about the link between cigarette smoking and cancer. So what we see is that cigarette smoking causes a lot of cancers, not just lung cancer, but not surprisingly, it affects your whole oral system, your larynx, your esophagus, your oral cavity, but it also affects your bladder. It affects your liver. It affects your cervix. It affects your kidney. So there's so many other types of cancer. My dad is a classic example. He's had kidney, bladder, and lung cancer. He's a lifelong smoker. And so his smoking probably contributed to the fact that he's had 3 different types of cancers. Okay.
So if you're smoking, stop smoking.
Yeah.
And you know what? And the data hasn't been brought together, but weed is probably no different. So you know what? Just of course, difference is you don't usually do 3 packs of weed a day.
Yes, we hope. Try some edibles,
yes,
buddy.
Okay.
So anyway, we see a really strong link between cancer sales and lung cancer mortality. So when the U.S. government started to say, hey, wait, we're having to deal with a lot of people dying from lung cancer and the cost of treatment and the terrible impact it has in society of having lung cancer. So the government started saying, hey, we're going to increase taxes. We're going to issue reports about the risks of secondhand smoke. We're going to start passing laws saying we can't have smoking on planes or trains or buses or inside buildings. And then we started to see the rate of cancer deaths decreasing.
So this is a public health initiative. That's what public health does, okay? We did the same thing with COVID, all right? It was first we had to gather information on COVID, and then once we gathered the information on COVID, then we started putting out recommendations, and then we saw the decline in COVID. Yeah. So this is what this is.
And interestingly, if you look at lung cancer rates around the U.S., there's a lot of culture that goes into it. Is it common for people in your community to smoke? So in California and Utah, smoking is not as common. So we have a much lower rate of lung cancer in these West Coast states. But if you go out to, say, Kentucky or Kentucky. They tend to
Or
smoke.
Fontana.
They
An
tend to
inside
smoke
joke.
a little more in Kentucky and West Virginia. And so we're seeing higher lung cancer rates in those places. So a lot of people will say to us, hey, it's all bad news. What's the good news? The good news is there's a lot that you can do to decrease your risk of cancer. So basically I say, don't smoke. Drink moderately, which is 1 drink a day for women, 2 drinks a day for men. If you're
If you have to drink, you don't have to drink once a day.
You don't have to drink once a day.
During the pandemic,
we recently cut way back. Let's just say
it was better.
It was time. The pandemic things got bad.
Forever.
So physical activity is really important. So exercise and maintaining a healthy body weight can decrease your risk of breast and colon and endometrial cancer.
So many different directions. You lose weight and then you get rid of the inflammation that causes cancer. We have these natural antioxidant enzymes that get rid of the events that cause mutations. So, I mean, it's not just epidemiology. There's like, hey, these worker bees are increased in your body when you exercise, and they help prevent cancer.
So eating a healthy diet, a vegetarian, Mediterranean-based diet will help. Alcohol use also causes a lot of cancers. Increases your risk for colon, rectal, female breast cancer.
It's this double-edged sword, because there's a little bit of stress reduction. High stress is another cancer-causing agent because of its relationship to diabetes. And then there's the sociality part, that is super important.
Absolutely.
But you can't abuse it.
I'm not saying never have fun. I'm just saying keep a handle on your risk.
Moderation.
And look at your risk factors. Absolutely. So anyway, before we go on, I want to also talk about a few other things that you can do to decrease your risk. There's a lot of cancer surveillance that you can do. So colonoscopies, mammograms, pap smears,
PSA tests for men,
prostate cancer, PSA tests, skin cancer. I get a skin cancer check once a year because I'm at higher risk because of my leukemia diagnosis.
And I'm at high risk because I'm Irish and I surf.
John's Irish and he's out in the sun a lot.
I have no pigmentation, and yes, your melanin helps protect the underlying cells that undergo division.
So reduce your risk of melanoma UV. By wearing sunscreen, wearing long sleeve shirts when you're out in the sun, rash guards if you're in the ocean, things like that. And for people who are at higher risk of lung cancer, so people who are longtime smokers who've smoked quite a bit over like 15 years, by the time you're age 50, you can get annual CT scans, low dose CT scans. And if you diagnose lung cancer early, you can surgically remove it, you can do some radiation treatment, and the survivability is much, much higher. Okay, so now we get into this data about new cancer cases. If it's red, that means it's increased. If it's blue, that means it's decreased. And if you look at what's increased, go up a little bit. So for both men and women, we're seeing an increase in melanoma, so sun exposure. So wear your sunscreen.
I'm going to guess because people are out there exercising and not wearing sunscreen, or going for runs. And I can't tell you how many more people surf now than before. It's crazy.
Kidney cancer is correlated to cigarette smoking. It's correlated to obesity. So my dad, who's a cigarette smoker, has also been overweight for a good portion of his life. Liver cancer is correlated to hepatitis. It's correlated to obesity. It's correlated to what was the other thing? Alcohol. Yes. And so a lot of the types of cancers that we get and that we see, we can screen for them regularly to reduce our risk. We can change our lifestyle to reduce our risk. So we do have a little bit of control over what happens to us.
And some of this is better diagnostic tools as well. What may have not been, I don't know if this article of this series report accounts for that, but we're much, much better at finding cancer earlier.
Yeah, so whenever you see an increase in cancer rates, you have to ask yourself, are we looking for it more often? Are we testing? There's been some debate in the prostate cancer community about whether we're over-diagnosing and over-treating people with prostate cancer. So that maybe we can back off a little bit in terms of screening people for that.
All the advances done in breast cancer, but having the 3D mammogram be standard of care now, you're picking up cancers that never got picked up before. So
yeah,
cool.
Yeah.
And then here's the good news. So
The good news is we have quite a few cancers where the rates are decreasing. So that's really, really good news when we see big changes. And we'll get even better news when we go down a little bit to the death rate.
this can be helped by vaccination, believe it or not, because a risk for some of the lymphomas is getting a really bad infection.
Yeah,
So,
absolutely. So, and I didn't talk about HPV yet. Because I'm a cancer patient, if someone said to me, hey, if you could have a vaccine that would have prevented your cancer, would you have done it? Oh, heck yeah. So I'm a big fan of HPV vaccine. Even one dose of the 3-dose series is shown to be protective. And the CDC changed the recommendations so that you're eligible to get HPV vaccines up to age 26. And if you're 27 to say 45, it's a conversation that you can have with your doctor. So typically what they want is to get you vaccinated before you've ever gotten HPV. And HPV is prevalent in our society. I think by the time you're our age, something like 80% of the people have been exposed to it. So it doesn't have anything to do with
getting it, but it's just that
yeah.
weird
I mean,
risk,
it doesn't have anything to do
genetics.
with your sexual behavior or like how many partners you've had. It's just out there. So everyone is exposed to it. We have
our niece got it. So,
yeah, 2 young women that we're close to were diagnosed with cervical cancer that was caused by HPV.
And then one of my work friends got throat cancer from it.
Yeah, and had some pretty tough treatment that he had to go through. So if you can, and there's research all the time about vaccines to prevent other types of cancer. Right. So when we look at our death rates,
it's a lot better than the last graph.
It's a lot better. Yeah. So we only have a couple types of cancers where we're seeing increased death rates, and we're seeing a lot of types of cancer with decreased blue lines that show a decrease in death rates. And so that's pretty exciting. And on both sides, men and women, for all sites, that's the black line, we're seeing a pretty significant decrease of over 2% for men and 1.9% for women.
Early detection and better treatments.
Yeah, so I'm pretty excited about that. One thing I'm worried about is the impact of COVID, because I was pretty careful during COVID because I'm immunocompromised. So there were certain doctor appointments that I put off. So I missed getting my mammogram that year, and I probably missed getting my skin cancer check. Thankfully, I wasn't due for a colonoscopy during the peak of COVID. But a lot of people put off colonoscopies and mammograms, and now they're out of the habit of getting it. So normally it's like if you're someone who has to worry about that, you're like, okay, it's March, it's time for my mammogram, time for me to go in and get this done. And so what we are worried about from a public health standpoint is that a lot of people have gotten out of the habit of having these screening tests done. And now we're going to have people getting diagnosed at a later stage of cancer.
And it takes off. I mean, it's not as treatable. Sadly.
Yeah, you have fewer options. So go down a little bit on the next little figure. And so what is expected to happen, unfortunately, in the next 10 years is that we're going to see what we call excess deaths from colon cancer and breast cancer in the US because of people who have delayed screening, delayed getting diagnosed, delayed treatment. And that's really sad. So
you could have in situ breast cancer, but then because you delayed it, it's metastatic.
Yeah.
And it's completely different treatment.
So check with your family members. Hey, were you due for a colonoscopy? Were you due for a mammogram? Have you gotten it done? These tests are relatively easy to do, and it makes a huge difference in your treatment options if you do get diagnosed. So let's talk a little bit about incidence rates. So here's where we get to some pretty bad news that, depending on who you are, but bad news for me as someone who cares about cancer patients. When we look at incidence rates, we look at, who gets cancer the most, and then we look at death rates, and we look at who dies the most. And so white people and American Indian Alaska Natives are the most likely to get cancer. But guess who's the most likely to die from cancer? Non-Hispanic Black people and American Indian Alaska Natives. And so we're seeing this is consistent across many, many types of cancer, that Black people see a higher death rate. And so that to me is really a tragedy, and it's consistent across men, it's consistent across women. And so we'll talk a little bit about why that is. Now, If you are a person of Asian Pacific Islander ancestry, then we have some good news for you, because you're, if you go up a little bit, just so we can see both men and women, then you have the lowest cancer rate. And you also have a relatively low, I think the lowest death rate. So something magical is happening in that community.
What is it? Is it diet? Is it exercise?
I don't think people know yet. Now, we also see low rates among Hispanics, but the bad news for the Hispanic community is that the research is showing that as people immigrate to the US, they have healthy lifestyles, healthy food, they're doing all these good things. They immigrate to the US, and then they start adopting the American lifestyle, eating fast food, drinking alcohol, smoking cigarettes, just not living a healthy lifestyle anymore. And so what they're seeing is, as people immigrate to the US and start adopting the American lifestyle, as each generation comes up, the cancer risk gets higher.
And so being highlighted right there.
So we do have to be concerned, if you are a group that starts out with a low cancer rate, to hang on to whatever good, healthy things you're doing in your community, so that you don't become the typical American high cancer risk person.
We have a May Messer where we went last year. We're going again this year. We went down to Nicoya, Costa Rica. And it was, just people really purposely have to work hard for the food. The food is beautiful, but where do we start? We saw Kentucky Fried Chicken down there. It just starts creeping in, and next you know,
it's so delicious.
The whole longevity equation disappears when you adapt the American diet.
So anyway, I want to say more about the racial disparity. When we look at the data of the racial disparity, go back up. That's HPV. Go up.
Okay, sorry.
Go up. When we look at the racial disparity and the effect on the Black community, it goes beyond socioeconomic issues. So some people say, well, maybe it's just access to health insurance. Okay, well, then you look at people who do have health insurance, and they're still getting diagnosed at a more advanced stage of cancer, and they're still dying at a higher rate. So then they said, well, let's look at Black people who live in communities that are wealthy versus white people who live in communities that are poor. And the Black people who lived in the wealthy communities were getting diagnosed later at a more advanced stage. So there's a lot going on here. Some of it is cultural and a lack of trust in the medical system. That, I think, is a problem we have to deal with. Some of it is the medical system and the way that they treat their patients who are people of color.
It's called bias.
It's bias. So if you are planning to go to medical school, please, when you are practicing medicine, you need to make sure that you're treating all of your patients the same. Are people of color being offered access to clinical trials at the same rate as white people? And I think the answer is no. I think there's an assumption that they won't want to do the trial, that they won't have transportation, that they won't be interested, they won't, blah, blah, blah. And so we need to make sure, there's so much that we need to do to improve the healthcare delivery, so that, I'm hoping in future years, when we look at these cancer statistics broken down by race and ethnicity, that the bars are all the same, that we don't see a difference.
And as a woman, when you were having some significant health problems 20 years ago and you sought help, what were you labeled as?
Oh, they just said, you're a lawyer and you have little kids, so it's stress.
And you're a hysterical female.
It turned out to be leukemia, but stress, leukemia, whatever. So that can happen.
Women don't get
and what I found, and for those of you who have dealt with bias in the medical establishment, what I found is they started bringing John to my appointments, and I would say something, and the doctor would be like, "Yeah, whatever," and then he would say the same thing I had just said, and the doctor would just like treasure every word that came out of his mouth. And so it was really helpful to me to have someone.
It's kind of also sickening.
It is terrible, but it helped me get better care.
It's like in Saturday Night Live, there was a skit with the interpreter. He said,
John's my cancer interpreter. So, and now I see a great doctor who's not like that at all. So I don't want to say that my current doctor is that way. So scroll down, because we talked about HPV. The big news with HPV is that in young women in the US, that cohort that had access to the HPV vaccine, although we have a lower rate of uptake of the HPV vaccine than most countries in the world, we are seeing a dramatic drop in cervical cancer. And remember, HPV causes cervical cancer, it causes oral cancer, it causes anal cancer, it causes rectal cancer. These are not cancers we want. And so I'm very optimistic looking at that data. So that's kind of happy news. So we've given you access to the National Cancer Institute site.
Just show some curiosity. Have fun with it.
And we have this video that talks about cancer biology. And this is something that people usually struggle with on the quiz. So I put a graphic in. We have these things called oncogenes and tumor suppressor genes.
Two major categories of genes that go bad that cause cancer.
Okay. In your body, the normal oncogene that isn't mutated, that isn't cancerous, puts a accelerant like gas on growth, right?
Right. Yeah.
Okay.
So when insulin, when you take in glucose, insulin says grow. IGF-1 is another one. It's a like growth factor. It gets released by the liver, and it says, okay, there's a bunch of food right now. We might as well produce a bunch of new cells. Okay. Unfortunate way of describing it. Name those proteins that are the gas pedals that say, okay, it's time to grow. They're called proto-oncogenes. They should be called normal genes.
Yeah. So a proto-oncogene is the normal form. When it gets mutated in a cancer cell, it becomes an oncogene. And so you've probably all heard about oncogenes being related to cancer. So they're putting the gas on the cell growth and the cell division.
Right.
A tumor suppressor gene is a gene that says, hey, wait, I want to slow down. I want to put the brakes on growth. I want to keep things from getting out of control.
And the reason you do that is you stop the cell from growing. Okay. All right. Time out. And then you send in a bunch of your specialists, other proteins, and they look for DNA damage, and they repair. Okay.
Yeah.
And then if the DNA damage is too far gone,
then your immune cells will go in and kill it.
They say, okay, that's it. We're not going to save the cell. It's time to kill it off. So but if you have this going all the time, this doesn't happen.
Yeah.
Right. So if you have gas pedal going, it's a problem.
So when you have a mutated tumor suppressor gene, it inactivates that gene. So it's not working anymore. It's not acting like a brake on cell growth. And so one of the famous tumor suppressor genes is TP53.
Mm-hmm.
So a lot of cancer patients have a mutated TP53 gene, and that usually means their cancer is going to be more aggressive and maybe resistant to treatment, et cetera. Now
they don't do the DNA repair, and even though there's enough repair for the cell to be tagged to be killed, P53 doesn't do either of those. So the cell survives forever.
So humans have two copies of TP53. Mom and dad. Elephants have, I think, like 40 copies. So elephants don't get cancer because they have a lot of copies of this tumor suppressor gene that are healthy and normal. So if one or two get mutated, no big deal. You still got all the other ones active and doing their jobs. So think about
stuff.
So that's everything for cancer.
And we obviously we provide links and other ways for you to get in there and educate yourself, especially if it's personal. So go in there and check it out.
Yeah.
Okay.
And if you or a family member gets diagnosed, you can always reach out to John or I, and we can help direct you to resources. And we've helped a lot of students, and so I love helping people who are newly diagnosed. It's a lot to take in, and sometimes people just need someone to point them in the right direction.
Remember, one of our students, her dad, had an aggressive form of glioblastoma, brain cancer, and they didn't know what to do because they didn't understand the biology. We explained it to them. Then, what about clinical trials? And we explained that to them. So, I also wanted to highlight this. See, this is our world in data. Awesome. This is what you're going to be gathering data from for your CT1. So you're going to get into this amazing database that I'll talk about in the next video. All right. Okay. All the way down there. Obviously, you could have opened your quiz, but by now, hopefully you understand that. You can open the quiz. You can do it with your friends, and you just kind of bang away at this and get it done.
Okay. So our discussion is about grief, and one of the famous people who talked about grief is Elizabeth Kubler-Ross, and she talks about the 5 stages of grief.
That's her right there.
So it's denial, anger, bargaining, despair, acceptance. And, when you get bad news, when I got my cancer diagnosis, I kind of went through denial, anger, bargaining, despair, acceptance. She's not the only expert on grief. And so if you watch the video and read about her work and it doesn't resonate with you, don't worry about it. There's a lot of different ways to grieve. There's no wrong way or right way to grieve.
I did this 3 weeks ago. I was in complete denial. I don't have COVID, not me.
Yeah.
Then I start bargaining. Come on, give me a, this, to have it. I really want to go surfing in a week, so come on. And then finally you go into acceptance when she stuck me upstairs
I made him
in
go into his
quarantine.
room and wouldn't let him
I
come
had
out
to accept it.
for
So
days.
anyway, you go with the when you've had a bad boyfriend or girlfriend, you break up, you go through death for that. So this is not just death, but obviously it's it's a bigger deal, I think, when it
Yeah.
comes to death.
And you can have something called anticipatory grief. So my dad has metastatic lung cancer right now. And so I know that he has limited time left. I'm worried about how the cancer is going to affect him. I'm worried about his quality of life. I'm worried about whether he's going to suffer too much before he dies. And so I'm anticipating his death and having grief kind of in advance. You might have grief when someone isn't dead, but they can't be present in your life anymore. So if you have an estrangement from a family member or a friend, or maybe you have a friend who's got drug or alcohol or mental health issues or some other issue, and they're not available for you anymore. They may not be dead, but you're still grieving that relationship.
This is how we cope with everything in life. We're complicated beings.
Yes. And the one thing I can say, as someone my age who's been through a lot of grief, it gets easier with time. So, you have to let yourself feel the feelings and realize things are hard initially. When my mom passed away suddenly a few years ago, I cried every day. I was just really distraught, and she was someone I really loved, and she was a good friend of mine, not just my mom, but a good buddy. And I really missed her so much. And now I'm to the point now, a few years later, where I can get comfort in thinking about the things we used to do together and looking at the things she's made a lot of stuff that she gave to me. So looking at her belongings and so over time it becomes less of just horrible pain and
There,
more.
she made
She
that.
made that. She was very crafty and,
She was one of
and
those old
creative.
old school farm
Yes, she
girls
was.
that could sew like no tomorrow.
And so over time, that grief recedes a little bit, and but it can be difficult for
And
a long
everybody
time.
goes through different phases. I was, so her mom, I can reflect on my mom. My mom lived a lot longer, right? So, Lorraine lived till she was
79.
79. My mom lived till she was 95. And it was a slow demise. And just to be honest, I was being, you guys may find this, you're the sandwich generation, you're torn. I was dealing with my own problems, dealing with Julie's cancer, dealing with my kids, dealing with work, and I had to deal with my mom. And so when my mom died, I went immediately to this. I didn't go through any of this. I was actually relieved because it was just better on everybody, including her. So
And she was ready. She
yeah.
was ready.
So I
So
jumped immediately to acceptance, and there was this sense of relief, and because I was driving all over the place, and it was hard. So
yeah. So sometimes you have that if your loved one is in their 90s and they've got a serious illness and you know that they've got limited time, you may get to acceptance faster just
right,
because you've already kind of been processing what's happening. So you can watch these videos. If you are able to speak to your experiences with loss or grief, it doesn't have to be the death of a loved one. You can. And some people I know, especially during the COVID pandemic, have had a little bit too much and very painful, difficult experiences with grief and loss. So
loss of a job,
you
all right.
can email me your response if you don't want to post it, if you feel like it's too personal. So sometimes people will say, well, look, I'll email you my response and then I'll respond to 3 other people or, whatever. We can figure something out for you. And if you don't want to talk about death, dying, loss, and grief, I can give you an alternative assignment. So we want to be flexible here.
Awesome. Very cool. Alrighty, guys. So here we go. We're a third of the way through the class. Basically, that's where we're off to. So peace, have fun, and we'll
Right
see you
on.
next time. Bye on.